Okay, well, good morning, everyone. It's nice to see everybody here on Sunday morning, so thanks for coming to join us. I'm Jessica Kendrick. I'm going to be the moderator for this exciting session about rest in peace kidney stones. We'll do some updates in both the diet as well as the medical management of stones. So I just want to introduce our speakers. Our first speaker will be Melanie Betts, who's going to talk to us about diet do's and don'ts for kidney stones. She's a nationally recognized kidney stone expert in Chicago. She started her career in nephrology at the University of Chicago. And then she started noticing all the significant gaps in the information patients were receiving, both online and through providers. So she founded the Kidney Dietitian blog to educate both patients and healthcare professionals. The Kidney Dietitian now touches about 20,000 people every day. So this is fabulous. And not only does she have time to do that, I don't know, but she's also the current chair-elect of the Renal Practice Group, president of the Illinois Council on Renal Nutrition, and is a member of the planning committee for the NKF. So a very busy woman. And then our other speaker is Dr. Megan Prochaska, who's a nephrologist and assistant professor of medicine at the University of Chicago. She has specific clinical and research expertise in kidney stone prevention, and she'll talk to us about medical management. But first, we'll have Melanie talking to us about diet do's and don'ts for kidney stones.
Thank you so much, Jessica, for that wonderful introduction. And I am thrilled to be talking to all of you about my very favorite topic in the whole world, which is kidney stones. And thank you so much for sticking with us until the very last day, very last session, not only on the last day. So let's go ahead and dive in. So I broke this down into very clear do's and don'ts of what we want people to do and not to do for kidney stones. So this, I feel like, should not be exciting, but I still hear people daily telling me that they get information from their healthcare providers that they should be limiting calcium, which is terribly wrong when it comes to calcium kidney stones. Instead of limiting, we actually want to make sure that we are getting enough calcium in for our patients with calcium stones. The American Urological Association, I kind of pull from the official AUA guidelines for the medical management of kidney stones throughout the presentation. So their language and their official recommendations is to consume 1,000 to 1,200 milligrams of dietary calcium for people with calcium stones who have high urine calcium and or oxalate. So why does this matter? Just real quick, again, this is kind of like decades, 2 decades old, right, Megan, of advice at this point, but just to kind of really drive this point home, here's my little cartoon guy. I call him Mr. McStoney. I use him to educate in a lot of my content. But he, you can see if he's eating a lot of oxalate, which comes from a lot of really healthy foods, as we'll talk about shortly, that a lot of that oxalate is going to get absorbed into his system and going to get excreted in his urine where it can cause stones. But if he is consuming enough calcium with those healthy, higher oxalate meals, much less of that oxalate is going to get absorbed, which means a lot less of it's going to end up in his urine and form stones. Instead, that oxalate is just going to get excreted in his stool. Also, calcium stone formers are at much higher risk of bone disease, right? Osteopenia, osteoporosis, and fractures and that sort of thing. And so we certainly don't want to be telling a population who's at higher risk of bone stuff to be eating a low calcium diet. You certainly cannot talk about calcium and stones without mentioning this randomized controlled trial in nutrition, which is so rare. It's so exciting to see. This was a paper published in the New England Journal of Medicine back in 2002. And essentially, they took a whole bunch of men with recurrent calcium oxalate stones and told them to follow a low calcium diet, which was, I believe, sort of standard of practice maybe at that point in time, or sort of a normal calcium. Like, we're not talking about a high calcium diet. We're just saying, like, just eat the amount of calcium that all of us should be eating anyway. And they followed them essentially 4 or 5 years. And they found that people who consumed enough calcium formed about 50%, were 50% less likely to form stones over that 5-year time period, which is pretty significant. And if we dive into their 24-hour urine test, we see that the biggest difference, there's a couple differences, but the biggest difference that really seems to be driving that difference in stone formation is lower urine oxalate, which makes perfect sense because they're eating enough calcium. Much less of the oxalate that they're eating is going to be getting absorbed into their system where it can be excreted in our urine to form stones. So we want people to be eating calcium. All right, the next thing is, please do not tell your patients to stop eating salt. The goal of anything in nutrition, essentially, unless we're talking about like an allergy or something, is never zero. We really need to help our patients understand what they should be eating. And I really think that telling patients to stop eating salt, and the same thing applies for anything. If we say stop eating protein, stop eating meat, stop eating potassium or whatever it is, they take that to heart and they're like, okay, like what do I eat? So my point of this statement is to just be really careful with your language. Of course, we know that excess sodium is certainly not great when it comes to kidney stone prevention. It definitely drives higher urine calcium, but kidney stone, in my experience, I may be biased, but in my experience, kidney stone patients are some of the most motivated patients ever, and they hear from a healthcare provider to stop eating salt. They're gonna look at that nutrition facts label and they're gonna see milk has salt. Basically every single food on this earth other than like fruit is gonna have some sodium in it, and they're gonna say, I literally can't eat anything. And so whenever you give any sort of dietary advice, you need to put it into context for our patients so they know what they should be eating. It basically results in that massive confusion and frustration. And also, if you are in fact eating the foods that we want our patients to be eating, which is primarily, unprocessed or minimally processed fruits and vegetables, whole grains, proteins, etc., there is totally an opportunity to add some salt to their food, right? Like if you go in and you put together a meal plan that's fully unprocessed, it's gonna be like 500 milligrams of sodium. So there's totally some place for most patients to be adding a little bit of salt based on what else they're eating, right? So just be very, very careful of your language, work with your patients, make sure that you're assessing what they're eating before you tell them that they can't eat any salt or they can't add any salt, right? Because there's a lot of nuance there. Or refer to a dietitian, because that's what we do, help them assess that and help them understand exactly what they should be eating. All right, the next thing is I would say that we need to stop recommending low oxalate diets. And I'm gonna talk a lot about this. This is probably the bulk of my presentation today. Instead, we really need to be focusing on reducing the oxalate bioavailability of the diets that our patients are eating, and make sure that our patients instead are eating a healthy, varied diet that happens to include some higher oxalate foods. So let's dive into what the AUA says about oxalate. So again, they say that we need to be getting in that calcium for people who have high urine oxalate. They also say that we should limit the intake of oxalate-rich foods for people with high urine oxalate. Note that does not say everyone with calcium oxalate stones. They also don't call out a specific amount of oxalate that we should be consuming per day. I also am going to quickly mention that only around 20-ish% of people with calcium oxalate stones have high urine oxalate at baseline. Just going to throw that in there as well. And they also mention that we should avoid vitamin C supplements for people with calcium oxalate stones. So here's my spiel on oxalate. So which foods are high oxalate in the first place? There is massive confusion about what a high or low oxalate food is. So there's no official definition. For like low sodium, for example, there's sort of a general, like the FDA defines a low sodium food as less than 140 milligrams of sodium is like a low sodium option, but there's no definition of what an high oxalate or low oxalate food is. And so I might say anything less than 50 milligrams per serving is okay. Someone else might say less than 5. So that like results in these, when we sort of try to put that into patient education, it results in massive confusion like of the good and the bad oxalate foods to eat, right? Even if we did have that definition, quantifying exactly how much oxalate is in food is very, very difficult. Apparently, it's a very difficult compound to sort of isolate and accurately measure in food, period. It also is one of the most highly variable nutrients, or not nutrient, a compound in food. So an apple grown in Michigan might be very different than an apple grown in Washington. Oxalate content is going to differ dramatically based on the ripeness, when it was picked, if it was cooked, how long that banana's been sitting there. Like all of these factors have a huge impact on how much oxalate is actually in that food. And so actually measuring and counting how much oxalate anyone is consuming is virtually impossible, in addition to the fact that oxalate obviously isn't on nutrition facts labels, nor should it be, in my opinion, but, and it makes it impossible. You have a piece of bread, like how in the world can a patient even begin to guess how much oxalate is in that piece of bread? Because it's going to be so variable based on so many things. All that being said, generally, when we look at some of the very high oxalate foods, and if you really must try to quantify how much oxalate, there is a oxalate list put out by Harvard that is generally considered to be like the most accurate, and they actually just updated it last year. But here are some of the extremely high oxalate foods. Spinach and Swiss chard. Spinach specifically is literally 700 times more higher in oxalate than even almonds or beets, all of these other high oxalate foods. A half cup of cooked spinach has 750-ish milligrams of oxalate. An ounce of almonds has 120. So just to kind of help you put that into context for the next couple of slides. Beets tend to be high, navy beans specifically, cocoa, potatoes, most nuts, although not all, and whole grains. I think that's another thing people don't realize when we are telling patients to eat less oxalate. Whole grains are very high in oxalate, and if you're asking someone to limit the oxalate, they're always, if they're reading and doing it right, going to be choosing those white refined grains over whole grains. So what ends up happening when we tell our patients to be on a low oxalate diet? They don't eat these foods because all of these foods are going to have oxalate in them. They're not going to be eating whole grains and choosing those white refined grains instead. No plant proteins, because pretty much every oxalate list out there is going to say no nuts, no beans, no seeds, no tofu. Most vegetables off the table, most fruits off the table, many fruits off the table, which is a big issue because we know that a lot of people in the United States are not eating a lot of these foods to begin with. And as we'll talk about next, these foods are the exact foods that are actually beneficial for kidney stone prevention. So when we look at sort of the dietary patterns that are associated with a lower stone risk, the Mediterranean-style diet and the DASH-style diet are consistently associated with way fewer stones. And I think there's a lot of dietitians and doctors in the audience, but probably most of us know that these are very plant-forward dietary patterns. By definition, they're gonna be high in oxalate because of the foods that they're promoting: fruits, vegetables, whole grains, nuts, seeds, those exact foods that we just said were higher in oxalate. Here's one study that looked at the Mediterranean-style diet specifically and took data from the Health Professionals Follow-Up Study and the Nurses Health Study cohorts 1 and 2, and basically looked to see how adherent people were to Mediterranean-style diet and how likely they were to have formed stones. And when they put all the data together, we see that people who were most adherent with a Mediterranean-style diet had about a 40% lower risk of forming stones. This particular study actually had 24-hour urine data on a subset of the people in that study. And when we look at all of these different 24-hour urine parameters, I have a pointer here. We have over here, right, the people who are most adherent with the Mediterranean-style diet and all this urine stuff. And we see that oxalate did go up, which is not surprising because a Mediterranean-style diet is going to be higher in oxalate. However, people following a Mediterranean-style diet also had higher citrate, lower sodium, higher potassium, which is a really good thing generally when it comes to calcium stone prevention, higher magnesium, which we'll talk about, higher phosphorus and uric acid, which is interesting, but whatever, higher urine pH, and also higher volume, which makes sense because fruits and vegetables are also providing fluid. And then the great news is that when we look at all of these supersaturations of calcium oxalate, calcium phosphate, and uric acid, so supersaturation is essentially a fancy calculation that takes all of the data in a 24-hour urine test together and puts together a risk essentially of forming that type of stone. In all of these calculations except for one, people with the higher Mediterranean-style diet adherence had a lower risk of forming stones, which makes sense because they formed less stones. So basically what this is telling us that yes, a Mediterranean-style diet or a more plant-forward style diet increases urine oxalate, but it also increases all this good stuff that outweighs that potential harm from that oxalate as indicated by these calculations, as well as the fact that these people formed less stones. So how in the world can this make any sense? Telling people who have calcium oxalate stones, which is, as we know, around 80% of the stones that people form, how in the world could we possibly tell them to eat a higher oxalate diet? So I feel like sort of, in CKD, we're getting away from a strict low potassium diet, and I feel like oxalate is decades behind that, because in both of those situations, it sort of massively simplifies human metabolism and nutrition, right? It assumes that how much oxalate we eat is how much oxalate is in our body, but there's a whole lot of other stuff that goes on, right? In reality, we can't just eat less oxalate. We eat less fruits, vegetables, whole grains, and healthy foods, which is going to result in a reduction in other good things for kidney stone prevention. It also completely ignores the fact that the liver makes quite a bit of oxalate every single day. The amount of oxalate that you eat only accounts for a maximum of 50% of oxalate in your urine, and that's highly variable by person. Sometimes it's as low as like 20%. So there's a lot of oxalate coming from other stuff that we're not thinking about when we're just honing in on dietary oxalate. And there's also huge differences in how much oxalate you absorb from your food anyway, based on your gut microbiome, which is a super trendy topic right now. How much calcium you're eating is a really, really big thing. How much fiber you're eating, all sorts of stuff. So ultimately, like just kind of simplifying all of this down to like, oh, we need to tell people to eat less oxalate is just kind of short-sighted in my opinion. All right, so here we're gonna dive into some of the beneficial components of fruits and vegetables, nuts, seeds, whole grains, foods that happen to be higher in oxalate for kidney stone prevention. One thing that most of those foods do is help increase urine citrate, and all of those foods provide alkali to help lower our dietary acid load. So if you want to super simplify, like PRAL or NEPA, however you want to quantify it, the bottom line is that meat reduces acid that our kidneys have to get rid of. And assuming someone doesn't have CKD, that acid ends up in our urine, where it isn't great for most types of kidney stones. And meat is oxalate free. So you put someone on a low oxalate diet, they say, cool, meat, right? That's all that's left to eat, which maybe isn't the best option. On the flip side, every single fruit and vegetable on the earth is going to produce alkali. And when we look at data that compares stone formers versus not, this is a case control cohort study, they look to see, people who are forming stones have a much higher dietary acid load compared to people who do not form stones. This particular study found that if you measure dietary acid load by PRAL, potential renal acid load, people in the highest tertile of PRAL had about a 50% lower risk of forming stones. And if you calculate dietary acid load by NEAT, net endogenous acid production, they had about a 2 times higher risk of forming stones and the higher dietary acid load. The AUA actually calls this out in terms of citrate. So the AUA says that we should increase the intake of fruits and vegetables and limit non-dairy animal protein, so essentially helping to lower that dietary acid load for patients with calcium stones and relatively low urine citrate. Citrate is a really powerful inhibitor of calcium-based kidney stones, and citrate is an alkali substance. So if we have a super high dietary acid load, our kidneys are going to be holding on to alkali, including citrate, because it needs to help buffer that, right? But if we have a lower dietary acid load, our body's like, cool, I don't need that citrate, and I'm going to dump it out in my urine where we want it to help prevent those calcium-based stones. So putting the AUA isn't super specific. They just say eat more fruits and vegetables and eat less meat, essentially. So I would say, to put that into more useful terms, that we should be aiming for at least 5 servings of fruits and vegetables per day. That's what the Dietary Guidelines for Americans say. And that for total protein intake, these are my numbers, full disclosure, I'm just making this up, but somewhere around 0.8 to 1.2-ish grams of protein per kilogram. Protein is tricky because that protein, we quantify protein and give protein recommendations in terms of total protein, right? And for stones, we really only care about non-dairy animal protein because that is the type of protein that increases dietary acid load. So, this is tricky, but if you need a number, those are my numbers, and there's gonna be huge differences based on the patient, right? Someone who is older, someone who's in a smaller body, who's malnourished, we're gonna be obviously on the higher end, right? Possibly lower for people in larger bodies. And please remember that this does account for protein in all foods. So there's going to be a little bit of protein in whole grains and vegetables, and again, pretty much everything we eat except fruit. Yes. Okay, moving on to fiber. The gut microbiome, I'm not going to go into it a whole lot, but there is a lot of super fascinating research going on with the role of the gut microbiome in both oxalate degradation as well as producing short-chain fatty acids, which seem to modulate all sorts of things that are beneficial for stone prevention. And when we eat fiber, generally good things happen to our gut microbiome, right? And this was demonstrated in a study that was just published a couple of months ago, late last year, that found that for every just 5 grams of of fiber someone ate per day, they had a 10% lower risk of forming stones, which is huge. Like 5 grams of fiber is like not even a serving of beans. It's like one large apple, right? So I feel like that's really just telling, right? Like, just get our patients to be eating fiber. And that's another benefit of eating more fruits and vegetables for stone prevention. Of course, we know most of us are not eating enough fiber. I believe the average intake in the US is around 14 grams per day, where instead we should be eating probably closer to like 25 to 35 or so per day. Another super fascinating thing when it comes to sort of a novel target in kidney stone prevention is magnesium. I feel like I mentioned this earlier. Magnesium is the trendy nutrient for all things right now. It helps with sleep and like everything under the sun, but it also helps with kidney stones. How? Magnesium, sort of like citrate, but it combined with oxalate. So magnesium can bind with oxalate, so then that oxalate isn't available to bind with calcium and form a stone. We do know that stone formers tend to have lower urine and blood levels of magnesium, and we know that eating less magnesium is associated with fewer stones. Which foods have magnesium? The exact same foods that we are limiting on a low oxalate diet. In fact, there was a study by Nori et al. Published in 2014 that compared a DASH-style diet with a traditional low oxalate diet, and they found that people who followed a low oxalate diet on magnesium, unsurprisingly, went down in their urine, whereas with a DASH diet, it went up. So, which makes perfect sense when you look at what foods they're actually consuming. So when you kind of put this all together, the pro of a low oxalate diet is probably urine oxalate will go down. That's pretty well established. If you put someone on a low oxalate diet, likely their oxalate will go down. However, I think the cons are quite significant. I think that it is impossible to get in enough fruits, vegetables, and fiber. They're always going to be choosing refined or white grains over whole. We're going to limit all of the really good things that we know can inhibit calcium-based kidney stones, like citrate or alkali, magnesium, potassium, which is a source of alkali phytate, we didn't even talk about today, but that's another really potent inhibitor of calcium-based stones. There's going to be this negative impact on the gut microbiome likely because we don't have fiber. We're also going to potentially be increasing saturated fat because we're limiting all the other foods that they have to eat. So they might be eating more meat. They're not going to be getting phytonutrients and a lot of other things that we know are beneficial for the gut microbiome. It's generally not good for us, like not just stones, right? People have to eat for overall health. And we know that eating more fruits and vegetables, shocker, is good for us. And also, in my experience, because it is so difficult to follow a low oxalate diet for all of the reasons I just mentioned, and people become so fixated, they're like, oh, I learned about oxalate, I have oxalate stones. It becomes like their focus in life to figure out what has oxalate and what doesn't, and it is so stressful and difficult and makes so much sense, right? You have oxalate stones, I should eat less oxalate. It becomes their hyper focus, and instead of focusing, they focus on that instead of focusing on things that we know are going to be a whole lot more beneficial when it comes to stone prevention, such as drinking more water, getting enough calcium, not eating a ton of sodium, or whatever the case might be for them. So what do you do? If you happen to have someone with high urine oxalate on a 24-hour urine test sitting in front of you, what do? Focus on calcium first. In my experience, 9 times out of 10, even if someone has high urine oxalate to begin with, assuming they don't have like enteric hyperoxaluria or some sort of other cause for that high urine oxalate, 9 times out of 10, if we can just get them eating enough calcium with meals, that oxalate comes tumbling down and we don't need to stress about oxalate whatsoever. I think it does make sense to eliminate super concentrated sources of oxalate. I'm not saying we don't need to worry about oxalate at all, but I think that telling someone to like temper the number of spinach salads they have is very, very different than putting them on like a 50 or 100 milligram oxalate per day restriction. Some of the most common concentrated sources of oxalate that I see are smoothies and juices, a lot of times because these have oxalate in them or spinach in them. Again, spinach has so much more oxalate in it compared to literally any other food. I believe that there was a study that found that spinach alone accounted for about 40% of the oxalate intake in stone formers. So like, just spinach, right? Don't worry about anything else. Just get the spinach down or out and get in the calcium and likely we're good. Supplements, I think, can be a very significant source of oxalate. Turmeric and cinnamon are pretty high in oxalate. I'm totally cool with using cinnamon and turmeric in cooking because realistically you put like a little bit of cinnamon on your oatmeal, no issues. But in a supplement form, like that's a super concentrated source, and I have definitely seen super high urine oxalates because of that. I think it makes sense to also make sure someone isn't taking a ton of vitamin C supplements. Again, thinking about the liver production of oxalate. The liver's super good at making oxalate from ascorbic acid, so we want to make sure that that's limited. I think limiting excess added sugar. We think that excess added sugar increases urine calcium, and so that is something also to kind of look at and make sure that's not driving up that urine oxalate, specifically fructose and like high fructose corn syrup beverages, and also consider non-dairy animal protein intake. The liver is also really good at making oxalate from amino acids, and if we're eating a ton of protein, that could also drive up urine oxalate. In fact, there was a paper published, a case study by Sharon Moe in Indiana that had a patient that was told to follow a carnivore diet by his PCP to help gout because some YouTube person told him to do that. And it was interesting because we had like before and after carnivore diet urine test, and oxalate went up like pretty significantly, like 10 milligrams per day into like 45-ish milligrams per day range on an oxalate-free diet, right? So it really just shows that there's a whole lot more going on with urine oxalate than just how much oxalate you're eating. Okay, my next do not is a give one-size-fits-all advice. We really need to be tailoring kidney stone nutrition interventions based on 24-hour urine collections, and I'm sure that Dr. Prohaska will talk a lot more about this in her talk. Because what is a kidney stone diet anyway? There is no single kidney stone diet. There's not even one kidney stone diet based on stone type. A lot of times people will say, oh, I have calcium oxalate stones, I have calcium phosphate stones, what should I eat? My answer is, I have literally no idea, because I don't know what's causing your stones. If I don't have a 24-hour urine test, I have no idea what's driving their stone formation, right? One person is forming calcium oxalate stones because of high calcium, another one because of low citrate, and like, if, based on those causes, my advice to them would be very, very different. I think some other benefits for personalized nutrition in general, not just for stones, I think it's a lot easier for patients. We know that change is hard, right? Any of us who have tried to make a change, whether it's more exercise or making your bed every day or whatever it is, like changing behaviors is really, really tough. And when we tell them, here is all of this stuff that we want you to do, eat less salt, eat less protein, drink more water, have lemon juice, right? Like a gazillion things, they're obviously going to be overwhelmed, and they're probably not going to do anything because they're like, forget it, like this is too hard. But if we can give them one or two pieces of targeted advice that is targeted to their urine calcium or their urine, chemistry, it's probably going to be a whole lot more effective, right? Also, patients are different. Patients are human, and eating is a very personal, cultural, religious, emotional experience. And so if you aren't taking patient lifestyle factors and food preferences into account when you are giving nutrition advice, I think we're completely missing the mark here, right? People are not the same. And I would also argue there's sort of an ethical piece here, right? Like if we, if we have the ability, and it's not that hard to get a urine test, we have the ability to get down to exactly what is forming their stones. Is it really ethical to say like, oh, drink some lemon juice when you have no idea if low urine citrate is even a cause of their stones? When we can get more specific, is it really right to be telling them all these things like, hey, this is going to prevent stones when it may or may not? Just for your reference, here's kind of my cheat sheet for the most common dietary interventions for kidney stones based on 24-hour urine test parameters that are most nutritionally relevant, and sort of like, again, my cheat sheet for what I would do if I see these urine parameters off. I see lots of cameras, so I'm going to pause. All right. I also I'm a dietitian, so this is biased, but I have to give a shout out to registered dietitians. I think it is not going to do much good to give a patient a handout and call it a day. We really need to help patients make dietary changes. Sort of the current role and the involvement of registered dietitians in kidney stone care, I think, is pretty bad. Most patients never see a dietitian. Most patients are given a low oxalate diet handout, I always say reprinted from probably 1976 and from the ER, and like probably don't get any more nutrition education. Less than 10% of patients will even get a 24-hour urine collection at all, which is a whole nother conversation, but that kind of is very a stark statistic when we're thinking about the quality of kidney stone preventative care that we're giving patients. Only 23% of urologists partner with a dietitian in any capacity, which tells me that far fewer percent of patients are actually seeing that dietitian. And also a huge issue is that dietitians are not trained in kidney stones, right? We have to learn about kidney disease. We have to learn about diabetes and heart disease and IBD and all these things, but stones is not part of that. So most dietitians have no idea what we should be doing for kidney stones. So we really need to be training more dietitians in stone prevention. So we even have dietitians to be a part of kidney stone care. I think when we think about what a dietitian does, there's two big buckets, right? We do nutrition education, which is simply telling someone what to do, right? Eating less salt is going to help you prevent stones, which is great, but there's a lot of data that shows that when we tell patients what to do, they don't do it. But what we can do to help them actually do it, to obviously improve that health outcome, is nutrition counseling. So nutrition counseling is helping them actually make that change, identifying barriers, setting realistic goals that are specific to them and their life and their foods, right? That, I think, is the real benefit of registered dietitians, because doctors do not have time to do that, right? And that is why dietitians exist, and we do have the time, and we are ready and willing to help patients do these types of things. Also, some quick shout out. So dietitians can change urine chemistries. This is data that I presented at the Rock Society meeting earlier this year. I have an online stone prevention course for patients, and I have pre-urine data and post after taking my course and helping patients identify urine test parameters and what to do about it. There's all the data there, but the take-home message is that significantly more people had normal supersaturations for calcium oxalate and uric acid after taking my course. So we do make a difference. Dietitians do matter. So in summary, nutrition is a critical component of kidney stone prevention. Low oxalate diets are outdated, and instead we must individualize nutrition recommendations for our patients based on 24-hour urine collections. We really need to be including behavior and diet counseling and not just education if we want patients to have any chance of actually making lifestyle changes. And we really should be including a registered dietitian that is trained in stones as part of the kidney stone healthcare team. So with that, I'll turn it over to Megan.
Thank you all. Thank you all for being here, sticking around to the very end. Thank you to the NKF for the opportunity to present today. So I'm going to review the medical management of kidney stones. We're going to touch on some of the stuff that Melanie just went through, but in slightly different ways. And I always think reiteration and certain very important teaching points is really key. So I have no disclosures. What I'm going to do is review the epidemiology of kidney stones. We'll talk about the basic workup for stone patients, and then spend most of the time going over the medical management for the most common kidney stone types. And as I move through each of these three things, I'm going to really try to highlight some of the updates as well. Okay, so starting in terms of epidemiology, kidney stones are very common and prevalence is on the rise. So it was updated again in the last couple of years, and the current lifetime prevalence in the United States is greater than 10%. This compares to about 10, 15 years ago when that was estimated to be 8.8. And when you go back into the 90s, it was more like 3 to 5. So certainly on the rise. And it's on the rise globally, but it does seem like there's a couple of subpopulations where it's particularly on the rise. So women are now catching up with men in terms of more women are having stones, and some of the non-white populations are also increasing in terms of how many stones they're having. Recurrence rates are very high. 30 to 50% of our patients who have had a first event will have a subsequent event. And calcium oxalate stones continue to be the most common type of kidney stones. You can see that for both of these figures, in both males and females, calcium oxalate stones are the most common type of stone for the vast majority of decades of life, followed by calcium phosphate and uric acid stones. And stones continue to be incredibly expensive. So, estimates vary, but it's certainly on the order of billions that we're spending every year in the US in terms of healthcare dollars. There's a number of important clinical risk factors for stones. Of course, a personal history, as I just mentioned, in terms of recurrence rates, and a family history also portends about a 50% increase in terms of stones. Patients who have an enhanced enteric absorption of their oxalate, so Melanie touched on that. I'll mention it a little bit more as we go through the oxalate part in a little bit, but there are certain conditions, malabsorptive gut conditions, essentially, IBD, pancreatic insufficiency, bariatric surgeries, that increase how much oxalate someone may absorb from their gut. Systemic conditions such as obesity and diabetes are two of the strongest risk factors for developing stones. And then gout, hypertension, and a couple of important dietary risk factors as well, much of which Melanie just went through. And one of the things that I think is really key for us to keep in mind, and I always try to emphasize it when I'm giving such talks, is because I think it's underappreciated, that our patients who have kidney stones also have a subsequently higher risk of developing osteoporosis and bone fracture, hypertension, CAD, CKD, and ESRD, as well as diabetes. So to me, this highlights that A, kidney stones are a systemic condition, and two, when we see this youngish person, maybe doesn't have a lot of other metabolic syndrome or obvious metabolic syndrome risk factors, their creatinine may be 0.9, they've had 1 to 2 stone events, that individual is at higher risk for these metabolic syndrome conditions, and we need to keep that in mind when we think about their longer term management. And so with that all being said, I hope that this room well appreciates that kidney stones are preventable. And yes, one of our primary motivations in terms of preventing stones is that we're trying to reduce the acute morbidity associated with the severe pain, the gross hematuria, which can be really scary for our patients. We want to try to reduce those events. But if we can also try to find ways to hopefully reduce the risk of these other chronic metabolic conditions, as well as try to reduce healthcare costs globally, but also for individuals. If a patient's sitting there in the ER, they are at risk for lost work wages. They potentially are going to be faced with high copays, things like that. These are all the different motivations that I use to try to prevent stones in patients. Okay, so who should be evaluated? The short answer, based on the guidelines, is that the recurrent kidney stone patients, and that's because of the recurrence rates we've mentioned. You can also see here that in green are people who have had a single stone, and if you've had more than one stone event, you can see that the probability of recurrence and the time frame during which they will recur becomes much shorter. And the risk goes higher. And so these are the people who absolutely need to be evaluated. I also am quite aggressive with my patients who have a solitary kidney, and this makes some sense in this, given that if they have a single kidney, if they have a large stone event, that could be pretty catastrophic if it were to jeopardize additional kidney function. And so I'm pretty open and clear with my patients that we want to be aggressive about stone prevention if they only have a single kidney. Okay. In terms of the evaluation, I take very thorough histories on all of my patients. I spend a lot of time really clarifying, Melanie talked about some of the supplements. She also talked about turmeric and apple cider vinegar is like a big rage right now too. I am very specific about my patients in clarifying those things because when we say, what medications do you take, they don't necessarily think of these things as medication. I don't think of apple cider vinegar as medication. So they don't think of those things in the list. And so I very specifically try to call out individual things and be very open-ended with asking what they consume because it's possible that what they're consuming could be affecting their urine composition, and I'm going to want to know about it. Of course, basic screening, basic screening, blood test, imaging, but really, an incredibly important part of a stone evaluation is going to be if we can get a stone analysis. So I also counsel my patients heavily to say, if you pass any stone material, please grab it. Try, if possible, try to retrieve it, because if we can get a sense of what that stone composition is, it can just provide, further and more important data. And, if they see a urologist who's not someone I know and have worked with before, I also counsel them to tell their urologist, if you're grabbing some stone material, please send it for stone composition, or at least give it to the patient and I'll send it. But still, with all of this, the bread and butter, absolutely, the backbone of our stone prevention revolves around the 24-hour urine collection. So the first time I meet someone, I always get at least 2. I'd love 3, but it's not necessarily patient's most fun test. So I'll accept 2 24-hour urines. And the reason why I want more than 1 is because, of course, there's day-to-day variability in everything we do in terms of the diet, whether or not we go to the gym. All of these things can potentially affect our urine composition. And the more data I have that I can work with the patient that we can together form a more comprehensive stone prevention plan. And so on the 24-hour urine, there's a number of things that, of course, are going to be directly measured here in a full stone panel, and then a few things that are going to be calculated, and those are going to include the supersaturations of calcium oxalate, calcium phosphate, and uric acid. So for those of you who don't order them and look at them every day like I do, this is a sample of a litholink. It does not have to be litholink that you choose in terms of your lab. I give this as a sample because I do use litholink. The key to me, in my opinion, is whatever lab, as long as your lab produces or is able to present a supersaturation, that can give you a lot of the data that you need to be able to work with the patient to form a good plan. I always start by first looking at the creatinine down here at the bottom, because this can help me confirm that it's an adequate collection. Of course, creatinine excretion should be relatively steady, and so I'm looking for these numbers to be within about 10% of each other. And if there is, big variability, if it's much higher or much lower, that makes me concerned that there's either an over or an under collection. But assuming that the collection is deemed to be adequate, I then move into the supersaturation, which for the litholink reports are located up here. The reason why my starting point with the patient is all about the supersaturation is because this is the risk number. I even tell my patients, this is your risk number. From a physical chemistry standpoint, supersaturation is the likelihood that in this case, stone material comes out of solution. And in practical purposes, on the page I just showed you, it's actually just calculated using an iterative computer program with a number of things that are taken into account into that calculation, with some of the biggest ones being for calcium oxalate, for example, the volume, the calcium, the oxalate, and the citrate. But what I call it a risk number because we've actually been able to show that that's the case. So this is some data from the Nurses' Health Studies, which are female cohorts. HbFS is a male cohort. And we showed that for the level of supersaturation, as the level of supersaturation was higher, the likelihood of being a stone former was also much higher. So if I'm seeing a patient and their supersaturation is up here in this range, my goal then is to bring them down here. So I'm going to try to lower their supersaturation. And my next step, once I see, okay, they have a moderate or a high supersaturation, my next step is then to go into those components that really strongly contribute to the supersaturation so I can form, as Melanie was talking about, that really tailored plan towards them. So, for example, this is also, on this slide, it's also going to be data from those same cohorts. So this map represents both males and females, and these are relative risks. So anything above the line for this in the next couple of graphs is going to be something that increases stone risk. Anything below the line is going to be protective. So when we see urine volume, we know that low urine volume drives up supersaturation, drives up stone risk. High urinary calcium drives up supersaturation and subsequent stone risk. Oxalate, of course, is similar to calcium. Higher is going to increase both stone risk and supersaturation. And citrate, as Melanie talked about, we want to be high. So low urinary citrate increases stone risk and supersaturation. And this is because citrate, as she said, is an inhibitor for stones. Citrate can also bind with calcium in the solution, and yet a calcium citrate complex remains soluble. So it's going to stay in solution, and that's going to decrease the availability of calcium to bind with oxalate, which of course is not a soluble complex. So when we think about low urine volume and citrate, high urine calcium and oxalate all increase the risk of stones. When I see my patient then who has that high to moderate supersaturation, I then look at these 4 parameters and say to myself, okay, which one, or sometimes it's more than one, is much higher and seeming to be the primary driver of this elevated supersaturation, and then I focus in on that. So if this person has a really high urinary calcium, I'm going to work with that individual for the different strategies to lower urinary calcium and not worry so much about the other ones, because like Melanie said, we can't, we have to be more focused in terms of, give them 1 to 2 things that are going to be really highest yield for them to try to lower their supersaturation and subsequent stone risk. Okay, so now we're going to spend the rest of the talk going through some examples. These are real cases. These are people I saw all in the last couple of weeks to months, essentially, as I was putting together these slides. So this is a 55-year-old gentleman. His stones are his only past medical history. And you can see that he has here, his calcium oxalates are elevated, his calcium oxalate supersaturation is elevated. The goal is for it to be less than 4. And actually, when you look over here, his uric acid supersaturation is also quite elevated. For supersaturation of uric acid, we want it to be less than 1. So whenever I see someone who has two different stone types that are elevated, really one of the biggest players who's probably driving up risk is going to be the volume. Now he has a couple of other things that are abnormal too, but certainly his low urine volume is driving up his stone risk. And so because the goal for urine volume for stone patients is going to be greater than 2.5 liters. This is in liters. And he's less than half of that. So, of course, it makes intuitive sense. To increase his urine volume, what we need to do is really increase his fluid intake. We have clinical trial data that showed that. It makes intuitive sense. But, you know, and some people just grab onto it. They buy a new water bottle that becomes their favorite water bottle, and they really can make the change quite easily. But not all of our patients. It can definitely be very challenging for some patients. Some are because of occupational hazards. You know, if someone's a city bus driver or, you know, works in a chemistry lab, they're going to have some occupational struggles to be able to increase fluid intake. But even without that barrier, a lot of patients have a hard time doing it. So in the last couple of years, this ongoing trial, the PUSH study, has been going on. They started enrollment in like 2017, and they've concluded enrollment now. And the rumor on the block is that the results are going to be published or presented at least at AUA, which is the American Urological Society, at their big meeting, which is next month, I think, in Vegas. And so we await the results of the PUSH study. What the PUSH study was a multi-center RCT where they used smart water bottle technology, financial incentives, other different adherence incentives to try to get people to drink more water. And so it'll be interesting to see, you know, what of their strategies really does work. What are the different things we can sort of offer or suggest to our patients for the ones that struggle to increase the fluids, to see what is going to be the highest yield to help them try to increase fluid volume for those of them who really could benefit from this. Okay, and so that's what I did. You can see I didn't just do that in isolation, but he brought his fluid volume up, or his urine volume up quite nicely, and both of his risks came down quite nicely to goal. So we're going to do this for all of our stone formers. As I mentioned, you know, we're going to try to aim for volume of greater than 2.5 liters. And there's a lot of fluids that are perfectly fine for them. It doesn't always have to be just water. Really, the only thing that I counsel my patients to make sure that they avoid are the sugar-sweetened beverages. We know that sugar-sweetened beverages, from an epidemiologic standpoint, has been associated with an increased risk of stones. And the thought here is that, at least acutely, we know when people take a sugar load acutely, there's a sharp increase. Even if they just have like glucola, there's a sharp increase in urinary calcium, you know, even if they hadn't had any calcium. And so we're cautious against the sugar-sweetened beverages, but otherwise most of the fluids are okay and on the table. Okay. So now let's shift cases to a 65-year-old man who has type 2 diabetes. You can see he's actually done a lot of urines for me, and I'm going to show you the rest of them as we move through his example. So he is actually doesn't have, you know, his risk is actually pretty close to goal, but he does have really high urinary calcium. And the next number that I look at on the page whenever I see someone's calcium be elevated is down here, his urine sodium. And the reason, of course, why I look at his urine sodium next is because we know that the #1 way to decrease someone's urinary calcium is to have them on a low sodium diet. And this is because there's really strong correlation between our urine sodium and calcium. Of course, our guts are very efficient at absorbing sodium, and that sodium ends up going back into the urine. So urine sodium is a strong marker of dietary sodium. And this is data that shows then the correlation between urine calcium on the Y and urine sodium on the x-axis. This figure actually demonstrates thousands of patients because each individual dot is actually a trial. In red are the values for individuals who are not kidney stone patients, whereas in blue, those are kidney stone patients. And you can see that for the same level of elevated, you know, there's a correlation here for the non-kidney stone patients as well, but kidney stone patients are particularly sensitive where if they eat more sodium and thus their urine sodium is higher, their urinary calcium really jumps up quite high. And this is because the thought is that in the proximal tubule, if you've eaten more sodium, so there's more sodium in the proximal tubule, this is going to decrease the drive for calcium reabsorption then in that proximal tubule. So that's the thought about why this is the physiology that we see. And consistent with this, Melanie showed you the data. The Mediterranean and DASH diets, which are, you know, lower in sodium, are strongly associated with being protective against stones. Okay. So that's what I had him do. I put him on a low sodium diet. He actually followed it really, really well. He's one of those people who, as Melanie said, he really takes to heart everything he does. He's a teacher, actually. And he followed it. So this is in millimoles. So this is on Litholink, getting something to 100 is actually that he really did consume 2,300 milligrams of sodium per day. And you can see his calcium came down quite nicely. It didn't come all the way to goal. For men, I typically, it depends a little bit because I'm also looking at stone risk and thinking about bone risk. But for men in general, I aim to try to get a calcium lower than 250. And so once someone has achieved the sodium intake, if their urine calcium still is above goal, the next thing I do is start a thiazide. So we have decades-old data in terms of thiazides. You can see here, these are some of the earlier thiazide trials. Hydrochlorothiazide, this was dosed at 25 milligrams BID. Chlorthalidone and dapamide, the longer-acting thiazides. All of these treatment arms did much better in terms of percent relapse compared to the control arms here. Now, some of you are saying, but wait a minute, the No Stone trial. So the No Stone trial, for those of you who are not familiar with it, was published about 2 years ago now in the New England Journal. And although it's really great and very exciting to have more larger trials in kidney stones, I want many, many more of them if we can. But as we all know, that's difficult to do. But the No Stone trial was actually a null study. It didn't, when you looked at just kind of if you read the abstract, you think, okay, thiazides don't do anything. But there's a couple of key features that are limitations of that trial that I hope that we all keep in mind. The first was the use of hydrochlorothiazide. In the stone world, we don't use hydrochlorothiazide very often unless we're going to be dosing it much higher, if they're getting like 50 milligrams per day. The 12.5 dose that they chose, I wouldn't have expected that to have an impact in terms of stone disease because I wouldn't have expected it to lower urinary calcium. It's just not potent enough or long-acting enough. And so that's the one thing to keep in mind. Now, I do think that this trial did say that, okay, hydrochlorothiazide is probably not a good effect, but I don't, effective treatment in terms of stone disease, particularly at lower doses. But it did not, to me, change the message that longer-acting thiazides could be beneficial. And the other thing I'll comment on is that when you look at some of their data in terms of specifically radiologic recurrence of kidney stones, which is one of the best markers to say, did stone burden change? The people who were in the highest doses actually did better. They had less increase in their stone burden overall. So myself and the folks who take care of a lot of kidney stone patients, we are absolutely still prescribing thiazides for stone disease and patients who are hypercalciuric, particularly if they've reached their sodium goals. So I use indapamide and, of course, get a follow-up BMP. I monitor closely. And so that is what I did for this individual. He had one collection that he did on his birthday. Not a good idea. Remind them to not do that on their birthday. So we did it again. I just saw him a couple weeks ago, and you can see his urine calcium has come down quite nicely. We haven't fully reached his supersaturation goal yet. He and I will see each other again in a few months, but he's made a lot of really nice improvements. Okay. So now we'll shift gears again. We have a 50-year-old female who has a history of stones. You can see she has a couple of different abnormalities with her urine and a really, really high supersaturation. But I'm going to focus for this case, I really want to focus just in on her oxalates, which are elevated at 50 and 55. So one of the first things I do when I think about someone's urine oxalate is I think about what's driving it up. And that's because when we have, and Melanie alluded to this, so I'll reiterate some of her teaching points in my way. When you see someone's urine oxalate, the oxalate that's in there is from one of two sources. It's either, a portion of it is from their diet, and from there's a percentage of dietary oxalate that gets absorbed. So if you have a high urinary oxalate level and you think it's being driven from this source, from the dietary source, it could be that someone's having high intake of oxalate-rich foods. Maybe they're having that spinach smoothie every day. We know that there's people who do that. Or it could be from someone who's consuming a more typical American diet in terms of oxalates, but they're absorbing a greater percentage of it. The vast majority of us absorb about 5 to 15% of our dietary oxalate. If someone has a malabsorptive gut condition and has enteric hyperoxaluria, they're absorbing more like, maybe, certainly higher than 15, maybe as much as 50% of their dietary oxalate. And this then can drive it up. And the reason why they absorb more of their oxalate is because in the condition of the malabsorptive gut, they malabsorb fat, free fatty acids. So there's more free fatty acids around. Those free fatty acids bind with the calcium, and that leaves more free oxalate around in the gut, and the colon is very efficient at absorbing that oxalate. The second source of oxalate, so all of us have a proportion of our urinary oxalate that is from our endogenous production, and Melanie also mentioned this. At times when the urine oxalate is very high, it's because of genetic conditions like primary hyperoxaluria, or PH. There's 3 different types of pH described now, and pH 1 is the most common, but those people have urine oxalate levels that are greater than 100. So if you see someone who's has a triple-digit urine oxalate, maybe they should be thought about in terms of primary hyperoxaluria. And there is some individual variation, which Melanie also touched on. People who have higher body surface areas, for example, they're going to have higher urinary oxalates. Okay, so once I've thought about in terms of what's driving it up, because of course that's going to be part of what can help us think about how to bring it back down if we need to. I'm also, and Melanie touched on this, thinking about low calcium intake. And the reason why is because we do know that when we just think about, the predicted probability of stone formation in general, calcium intake here on the x-axis, you can see here there's this really nice sweet spot where around 1,000 to 1,200 milligrams, which as Melanie mentioned is the AUA guidelines for calcium intake, the probability of stone formation is the lowest right here. But if you go up from here, or if you go down in terms of calcium intake, 600, 400 milligrams of dietary calcium per day, you can see there's this very sharp rise in the probability of stone formation. And the reason why is because, of course, people are then in this low calcium diet absorbing a greater percentage of their dietary they're absorbing a greater percentage of their dietary oxalate. So similarly here's this calcium intake on the x-axis, but now oxalate absorption from the gut is on the y-axis. The same point, about 1,000 to 1,200 milligrams per day, you can see that the oxalate absorption is relatively low, but if we decrease the calcium intake, again, that similar sharp rise, they're absorbing a lot more of their dietary oxalate, and that oxalate is an end product of metabolism. The only thing it can do is go out in the urine. And so that's why, of course, our low calcium diets are associated with higher risk of stones and raises urine oxalate. And like Melanie, I still routinely get patients who come in and say, oh, but doc, I lowered my calcium in my diet because my calcium is high. And I have to say, oh no, let's reverse that. So this happens all of the time, even though the data on this has been going back decades, but well before I was even a nephrologist. And yet there's still a lot of misinformation out there that we need to help correct for our patients. And as Melanie mentioned, even though it has nothing to do with oxalate, this is also a dangerous strategy. The low calcium diet is also a dangerous strategy because of the risk of osteoporosis, osteopenia, and bone fractures in our stone patients. Okay. Melanie showed this data. This is from the Borhe low versus normal calcium diet, and she mentioned that at 3 years there's this really very clear split where the people on a normal calcium diet, 1,200 milligrams per day, did much better in terms of percent relapse compared with the low calcium diet of only 400. And she mentioned that the mechanism really driving this based on the urine composition was high urinary oxalate in this low calcium group. Okay. And so that's actually what we did. My patient, she was not eating very much calcium. One of the things we did is we had her eat more calcium, and you can see her oxalate came down nicely, but her calcium did not go up. And she drank more fluid too. So again, I didn't just do this in isolation, and you can see her risk came down quite nicely. And we still have some more work to do, but certainly some improvement. And so you'll see, I don't need to tell you guys all this. And in fact, I don't really need to tell you any of this part because Melanie just spent a really nice, just gave you a really nice talk on, whenever I talk about lowering oxalate content in diet, I'm very intentional about it. I'm very specific. I really focus on just like, okay, let's really limit this spinach and think about substitutions. And I definitely don't do it in a vacuum. I do it with dietitians. I cannot express my love enough of dietitians, and I'm not biased. So I can say that, I guess maybe maybe I am because I love dietitians, but definitely our dietitians are hugely helpful here because of the fact that, we need to have a good, I do use the Harvard Nutrient Database. We need to have them, our dietitians, as Melanie just really described, can help us guide patients in terms of this discussion quite well when it's appropriate. Okay, so shifting gears again, now I have a 52-year-old female. She has hypertension and kidney stones. And you can see here that really her biggest thing in terms of stone risk is low urinary citrate. So Melanie talked about this. I don't need to go through it. We want to increase fruits and vegetables, but there's often times where that's not enough. So then that's when I rely on supplemental alkali. Here's a couple of studies that just show that, using potassium citrate or magnesium citrate, the treatment arms did much better in terms of percent relapse compared with the control arms. I often use potassium citrate. It does not have to be potassium citrate. It can be any of an alkali if you have an indication for, if someone's anxious about their potassium or something else, you can choose other things. If they have CKD, for example, sometimes there's, people don't want to be on supplemental potassium. But you can think about different types of alkali that can help to that can be beneficial in terms of this. And the other thing that I think is also easy to forget is that a lot of times people just need to have their hypokalemia corrected. So the hypokalemia can cause low urinary citrate, and it does so because hypokalemia causes an intracellular acidosis for the proximal tubule cells. And so, and if a proximal tubule cell has an intracellular acidosis, that increases the proximal tubule reabsorption of citrate, which then of course decreases citrate excretion, decreases urine citrate levels. And so, and also the sometimes low urinary citrate is genetic, and you can give people tons and tons of potassium citrate and their urine citrate doesn't really budge, but you might see their pH go up. So I just caution you against that as well, because if we drive up the pH too much, you can increase calcium phosphate stone risk. And so, if you see someone whose citrate isn't really budging much, keep in mind that it might be a genetic condition, and maybe we should focus our strategies on other urine parameters. So this lady was on hydrochlorothiazide for her blood pressure, not prescribed by me. She didn't need it because her urine calcium, from my perspective, because her urine calcium was not terribly high. But by starting her on potassium supplementation and correcting her serum K, we brought up her citrate quite nicely. Okay, and so the last case that I have is a person who has Crohn's disease and uric acid stones. So you can see here her uric acid stone risk, again, we want that to be less than 1 in terms of her supersaturation. And uric acid stones are very, very heavily dependent on low urine volume and low urinary pH. So of course, in identifying causative factors, I'm looking for things like GI disease that can often contribute to these. And if possible, working with the gastroenterologist and the patient to try to mitigate, their overall, try to improve their GI symptoms to help this urine composition. And then I'm really focusing on increasing the urine volume. We talked about that, and then alkalinizing the urine. We also talked about that. So this is not, starting potassium citrate for a uric acid stone is not about the citrate. It's really about increasing that urinary pH to closer to 6. We do try to avoid it from going too high, above 6.5, because of that calcium phosphate stone risk. But this is really the bread and butter. You can put tons and tons and tons of uric acid in someone's urine, but if you make it alkaline and you make their urine volume adequate, they're not going to form a kidney stone. And so that's why I have no patients who are on allopurinol for uric acid kidney stones. They might be on it for gout, but we don't put people on allopurinol for this reason. We just alkalinize the urine. And that's what I was able to successfully do for her, and she's doing really well right now. Last word, I'll just say, in terms of future therapeutics, SGLT2 inhibitors have like a bunch of indications now. Stone's not quite yet, but earlier this year, the Sweet Stone trial was published. And so what they did is they took calcium-based kidney stone formers, uric acid stone patients, and they put them on empagliflozin for 1 month. And at the end of the month, citrate was higher, and there was a reduction in both calcium phosphate and uric acid supersaturations. So certainly this is going to be an area of research over the next couple of years in the stone world, and hopefully maybe by the next guidelines and in the next couple of years, we're going to actually have another tool in our disposal for stones, because everything that I presented today in terms of thiazides, alkali, these have things been around for decades. And so it'd be nice to have something else that we can offer our patients. So with that, I'll conclude just to say, if it hasn't already become obvious in my talk, with my talk about dietitians, is that stone condition, treating stone disease is absolutely multidisciplinary. The patient, nephrology, urology, dietitians, all different, our advanced practice providers. There's so many different people who are an important part of this multidisciplinary team. And then the rest of this I've sort of reviewed throughout the talk. So with that, I will say thank you. Thank you to the NKF. Thank you all for being here. And then our stone program as well.
Great. Well, thank you all for staying. I know we're a little over, but if you have questions, please come up to the microphone. Feel free to ask them. I'll start with one that's in the chat for you guys. Kind of talking about, what do you recommend if people are vegetarians, they don't eat dairy? Do you recommend calcium supplements to increase calcium intake?
So generally for most patients, we want to avoid calcium supplements because there's a bit of data that shows that calcium supplements actually increase stone risk, likely because of a higher jump in urine calcium versus like natural occurring calcium. So in those situations, if they don't consume dairy, and there's a whole host of reasons, obviously, why people don't consume dairy, I do recommend plant-based milk substitutes. I know that they are kind of like a supplement, but in my experience, I don't see urine calcium spikes the same way that I do with pill calcium supplements. And also making sure they consume it with meals, because I think if you are going to do calcium supplements, as long as it's with a meal, and it's not a ton, right? Like we want it to be like 300, 250, 300 milligrams of calcium, then generally it's okay. But I do plant-based milk subs first. And also you can get a little bit of calcium from like green leafy vegetables, salmon, these types of things.
Yeah, I'll just add that there are definitely cases where I use calcium supplements, but to Melanie's point, I really hammer home with patients that it's to be consumed with meals, and because of that oxalate binding properties. And there are, I didn't go through some of the more complicated stone patients, but if our patients do have enteric hyperoxaluria, a lot of them do have issues with being able to consume, because they often have GI disease, and that can limit their dairy options. And so for them, I will consider and have patients who are on calcium supplements. And I sort of make the quip to them, but your supplement doesn't go in the bathroom, it goes in the kitchen. You want to be eating it with meals. And usually we work very specifically in terms of calculating out what they can get from some of the non-dairy sources of calcium. And then we try to get up to 1,000 to 1,200 milligrams, if we think they're getting 500 from non-dairy sources, we then say, okay, then let's get the rest of it with supplements, but you should consume it with meals. And we sort of think about when their biggest meals are as well, and try to plan it that way. So we do use it. We just are very intentional about how we use it. Yeah.
Another question you guys would get about using like sugar-free flavoring or lemons or other things for the,
Yeah.
do you do that?
Sure. I have no issues with artificial sweeteners. I think it's a great way to get people to drink more water. And lemon juice, I don't love lemon juice for the purposes of increasing citrate. I think the data is a whole lot clearer that we can get citrate up a lot better by reducing the dietary acid load. Plus, in order to actually increase urine citrate with lemon juice, you have to be drinking like a quarter to a half a cup of lemon juice per day. Like, ugh. But that being said, if it gets people to drink more water, cool.
Yeah.
And then patients who are recurrent calcium stone formers and they're normotensive, would you initiate hydrochlorothiazide?
Yeah, so again, I don't use hydrochlorothiazide because of, I didn't use it before, and then No Stone kind of confirmed that, but I do use indapamide. And so yes, even if they're normotensive, I do, and I have a lot of patients, and I'll have some people who, their systolic might be like 105 at the starting point, and I'll still, they actually do surprisingly okay. For those folks, if I'm worried about their dropping their pressure, of course I counsel them, and we should have a good, discussion about it beforehand. But the one reason why I like indapamide actually is because it has the 1.25 dose. And so I'll just start them on the 1.25, and we'll if they can't tolerate it, then we'll stop. And surprisingly, more people than you would think actually can tolerate that lower dose of indapamide. But if they can't, then we go back to like, okay, well that one is not, so thiazines aren't going to be an option for you. So we try to figure out how we can mitigate other things. But yeah, I do try it. Yeah.
I'm sure they'll hang around if you guys want more questions, but we'll let you guys go. Thank you for this. Okay, well, good morning, everyone.